Hi, good afternoon. I'm Bryan and I'm joined here by Naveed Sattar. He's a Professor of Metabolic Science at University of Glasgow. Thanks for joining me today, Naveed.
No worries, a pleasure.
Naveed, the healthcare of diabetes has came under criticism recently. First of all, how would you describe the current standard of diabetic healthcare?
I think it's actually it has been perhaps somewhat unfairly criticised. And the reason I say that is that if you look at the trends in health statistics, patients with diabetes who develop diabetes, individuals who develop diabetes, are actually living longer than ever. Their rates of heart disease have come down substantially. That it's emerging evidence we're picking up the disease sooner than we did before. Okay. There is also emerging evidence that their amounts of eye disease, at least at the point of diagnosis, is less than it was before. And there is also evidence that we're having less amputations. Now, on the other hand, there's an increasing number of individuals who are developing diabetes, which is a big concern, and that's because of two main factors. One of the main factors, of course, is actually rising levels of obesity, so that's driving more people with the diagnosis, not only sooner, but also because obesity is a big factor in the cause of diabetes. And the second factor that's leading to more diabetes, more individuals with diabetes, is increasing life expectancy. So if people are kept alive longer with various therapies, then they have a longer time to develop diabetes. So those two things are pushing more patients into the pot, as it were, and those two things themselves are providing huge amounts of pressures on the system in terms of workload, and I think that's probably where the crux of the criticisms have come from.
I see. So even though if the life expectancy is longer with them, does that mean? Do you mean like with still with complications like amputations, etc.?
Well, no, it's two things. One is that yes, no, you're partly right. So 25 years ago, let's take a scenario where we didn't have as many good drugs that were able to keep sugar levels down, but equally we didn't commonly treat patients with diabetes with tablets that lower your cholesterol called statins.
You're talking about type 2 here?
Yeah, type 2. Yeah, and it's also partly in for type 1 as well, but let's talk about type 2, which is the majority. Then there was some evidence at that time that the life expectancy was shortened by around about 15 years in patients with type 2.
Yeah.
The most best recent analysis, which is some work which I was involved with, collating data from many studies, is that life expectancy has improved substantially, so that if you have diabetes now at the age of 50, rather than losing 15 years of life expectancy, or you lose about 6 years. Right. And I think that figure has probably also improved over the last decade or so, particularly as we're now much more commonly treating patients with diabetes with cholesterol-lowering tablets and blood pressure medications. So that those two factors themselves have massively improved cardiovascular health, so reduced heart deaths. But in addition, at the same time, I think we are getting better at screening for various complications and doing more rigorous work. Having said that, I think the recent reports effectively alerted to the fact that we could still do even better than that.
Yeah.
And I think that's so. If those recent reports were done in that context, I think it would have been better. But of course, people who have advocacy for their particular disease, for diabetes, will want to make a big shout. But just having other people give a better context of it is probably important as well, rather than just seeing the negative. There's lots of positives about diabetes as well.
Now, almost 3 million people in the UK have diabetes. Only 10% of those people have type 1, which is insulin dependent.
Yeah.
Now, this is generally treated and monitored by the patient themselves. Now, some argue that type 1 diabetes is therefore an independent disease. Would you agree with that?
Well, it's different from type 2 in the sense that individuals who develop type 1 have to go on to insulin because effectively, for whatever reason, whether it's genetic or viral, their pancreas is no longer making insulin and they need insulin. So in that sense, the cause of the disease is different from type 2, where the body still keeps making insulin. It's just that the patient, the individual in type 2 makes enough insulin, but not enough to overcome the body's resistance to the insulin, and the body's resistance to insulin is driven primarily by their levels of obesity, along with their, a few other factors linked to their to their characteristics, which includes your ethnicity. So South Asians have a higher risk of type 2. Men have a higher risk than women, which is not commonly known for the same level of weight. And also if individuals have a family history of diabetes. So the causes of type 2 are vastly different from the causes of type 1, and so they are different diseases. Having said that, there's been a recent paper published from the data in Scotland. Again, heart disease rates in type 1 have also come down more so than people perhaps imagine, but it does remain vast areas that we need to improve, particularly in the levels of average sugar control in individuals who have type 1 diabetes.
I'm saying it's like people are saying it's independent. Okay, so how can healthcare be criticised if it's if you're treating yourself and
well, no, it's not, actually okay. I didn't probably address that specific point. Now, it's not necessarily people with type 1 aren't left alone by any means. In fact, I think if anything, individuals who have type 1 diabetes are seen more commonly in hospital settings with specialists than are people with type 2. So they are seen. I think it's a misnomer to say that type 1 individuals with type 1 are left alone. That's completely not the case. Yeah. So if you have type 1 diabetes, not only are you usually seen by a GP at some points, but more you're usually seen in a hospital environment nearly all of the time as well. Whereas if you have type 2 and you've just had diagnosed and uncomplicated, the vast majority are now seen only in the general practice. So if anything, individuals with type 1 get better care or more specialist care, shall we say, than most patients with type 2. Right. So I think that's a bit of a misnomer, actually. What we don't know about type 1 is at what point, we try and keep the sugar levels down. What we don't know is at what point do we start treating their heart disease risk. When do we give them a tablet that lowers cholesterol? Should we give it, at what age? And the reason being is because type 1 can develop, from any age really, but usually the average age of diagnosis in type 1 is around about 14, but can go from anywhere from birth up to 60 or 70. Yeah. But on average is about 14, whereas the average diagnosis for type 2 is about their late 40s or 50s.
And as far as complications go, is it just the same risk with type 1 and type 2, would you say?
No, aggregating risk depends on many different things. So because individuals develop type 1 at a lot younger age, they often have a longer what's known as exposure time. If you develop diabetes an average age of 14, you have to live with high sugar levels for far longer. Yeah. So in type 1 diabetes, the sugar levels being elevated becomes a bigger part of the cause of their complications than other factors. Whereas in type 2, which is linked more to obesity, not only sugar elevation but also blood pressure elevation and abnormal cholesterol and other blood fats contribute in a different way as well. So there's complexities. So our main goal in type 1, particularly if you develop it relatively young, is keep the sugars as well controlled as we possibly can. Okay. But once they've had it for a number of years, then we will start to consider giving them a tablet to lower cholesterol and blood pressure. Whereas at the point of diagnosis of type 2, because it's given at an older age, we tend to start statins, which lower cholesterol, and blood pressure tablets pretty much straight away in individuals type 2. Yeah. So there are different things going on there.
Yes, but what I was going to say is, to what extent are developments being made to treat diabetics?
Well, in type 1, of course, the vast majority of individuals of type 1 have to, inject with insulin. Yeah. So there are improvements, clearly injecting with insulin. They have to watch what they eat in terms of carbohydrates, and also then tailor their insulin doses to match their lifestyle. So there's lots of issues with type 1. There are improvements on the go, in terms of insulin pumps for some individuals. There are other improvements in terms of in a very, very small minority where they have, pancreatic transplants. But those areas are very early on. So I think the big change, hopefully, is if we can afford more insulin pumps, that will help people with their lifestyles who particularly have problems with certain issues in terms of controlling their sugar levels. So there are technology-driven improvements in managing sugar levels in type 1, which are starting to be used more often, but of course they cost more money, and costs are something that we have to now look at even more closely in the context of a cash-strapped, economy.
Yeah, exactly. And would you say the likes of Diabetes UK contribute to that?
Yeah, no, Diabetes UK. I've worked with Diabetes UK
Yeah.
in different guises. Part of the science research group, and more, and I helped with, their meetings and teaching and so on. Yes, no, they do a very good job of providing an advocacy for patients with diabetes in terms of improving their health care, supporting the relevant researches, et cetera, et cetera. So yeah, Diabetes UK are a very good body for them, and also I think are efficient with the level of funding. They don't receive the same level of funding as heart disease, so British Heart Foundation receives a lot more money than Diabetes UK. But of course, reflecting heart disease as being still the major killer, but diabetes rates are rising. So I think it's something that is something that, in terms of funding, and Diabetes UK would like to stress that they are worthy of more funding because it's becoming a more common disease, as it were.